Yes, sir.
Hello, Dr. Onkar, welcome.
Thank you, sir.
Dr. Kripa.
Hello, sir.
Yeah,
Good evening.
great. Good evening. Is Dr. Bala there?
I'll check with Dr. Bala, sir.
Yeah, please check with him.
Sir, Dr. Balakrishnan joining in a minute.
Okay, fine. So I think I will informally start the proceedings by welcoming everybody to this grand round on the 29th of September. I think we are having a lot of inclement weather in South India, a lot of rains, and I'm thankful that our connections are still intact because it has been on and off since the morning, the rains and the connections. So welcome everybody, and we will wait another 2 minutes for Dr. Bala to come online. Otherwise, we would start with the introduction of our presenters. So I just want to wait for just 2 minutes. So we are looking forward to increased participation of doctors with special interest in vertigo. We hope to keep these grand rounds informal. We hope to educate ourselves incrementally. We have chosen a pattern of one presenter and two experts who will add their knowledge to the presentation. But we will always throw open the meeting to the house, and we welcome uh, comments from the audience also. We would like to keep these Vertigo grand rounds going, and wherever you are in India or the world, if you have an interesting case you'd like to share, feel free to reach out to us, and we'd be happy to accommodate you. This is we, we hope an inclusive meeting, not an exclusive one, but we hope that everybody will learn from this. So I think while we are waiting for Dr. Bala to come on board, I'd like to start off by introducing the chief speaker of today. Dr. Onkar Ramraj is our speaker of the day. He is an established ENT surgeon who's currently practicing in Bombay. I must say, from his address, in an upmarket region of Bombay, which is in Juhu area, where all the film stars tend to accumulate, and therefore I'm sure he has interesting clientele. He was a graduate of the prestigious Grant Medical College and JJ Group of Hospitals. He's been a consultant in many hospitals in and around Juhu, such as Sujay Hospital, Excel Medical Center, and he brings a dedicated interest in vertigo. He was also a faculty in the KJ Somaya Medical College, and we look forward to his presentation. And we are not allergic, there are a lot of advice flowing in. We're also happy to have as our expert panelists today Dr. Kripa. Now, we know Dr. Kripa extremely well because she is very much part of our team. She also is a certified vertigo specialist. She has a background in ENT. She has completed her post-graduation in the Deen Dayal Upadhyay Government Hospital in Delhi. She has worked in Topiwala National Medical College and therefore also has a lot of Bombay experience. Had a stint with Grant Medical College and JJ Hospitals. She has been with Cyclops for many years and has been an enthusiastic teacher. We look forward to expert opinions from Dr. Kripa. We also have,
Thank you so much.
not at all, Betty, you have earned it. We also have Dr. KG Balakrishnan. I hope he's online. Has he come in? I'm unable to see. Okay, but while we are waiting for him to come in, I'd like to say a few words about him. He is an extremely well qualified doctor who has qualified from Tanjavur Medical College, his MBBS, went on to do his post-graduation from Jipmer Pondicherry, which is a prestigious national institute. He did his DNB and then moved to UK, obtained both his FRCS and his FRCS ORL HNS, and then has been practicing in Coimbatore. So the benefit of his vast experience has been brought back to India, and we wait for him to come online. But without further ado, let us commence with the the presentation of Dr. Onkar. Dr. Onkar, would you like to start your presentation? Then you're at liberty to share your screen and go ahead. Dr. Onkar will present his case undisturbed. At the end of the presentation, we will get comments from the experts, and then Dr. Onkar would sum up his readings into the details of his case. Dr. Onkar, the stage is yours. Please go ahead.
Yeah. First of all, thank you for such a kind introduction, sir. And at the outset only, I would like to thank Team Cyclops for giving me this opportunity to present a case in the Vertigo Grand Rounds. I'll just start with sharing my screen. Am I audible? And is my presentation visible?
Dr.
Yes,
Omkar,
you're
your
audible.
presentation is visible.
Yeah. Thank you so much. When the feelers were a very good evening to everyone. First of all, to start. Uh, I really appreciate this is a beginning of a very long weekend, and those who have taken out their time to attend this, thank you so much. So, uh, when the feelers were sent out yesterday on social media and email, everyone started asking me what is the meaning of this title. Don't miss the mules. So it was after this case, I learned something, and I came across something and I learned something, and this statement is what was my takeaway from this case. So I will explain it once my case presentation ends. There is an explanation to this. So let's start without further ado. So this starts 3 years back. This 65-year-old female came to me, was brought by her son with a complaint of dizziness with fall one day before. While she fell, there was a head injury. Her head struck the side of a table. The patient then stood up by herself after a few seconds. But since then, there was a persistent sensation of lightheadedness and dizziness. There was no previous history of nausea, vomiting, convulsions, or dizziness. There was no previous history of fall. There was no history of headaches, or phonophobia, or photophobia. And she had no comorbidities, no known comorbidities till then. No history of hypertension, heart disease, diabetes mellitus, and was not on any medication whatsoever. So why did the patient come to me? That is also an interesting story. The patient was referred to by my anesthetist friend because she was his relative, and the MRI, because the fall was there, so MRI was done by a physician, and the MRI of the brain showed inflammatory soft tissue lesion in the right middle ear and epitympanium extending into the mastoid air cells with erosion of mastoid bone. Now, as an ENT surgeon, when a patient with dizziness and such an MRI picture comes to you, you always think of, oh my God, this might be a complicated mastoid and might be an intracranial invasion or something like that. So might require surgery. So then I started with my ear history. So surprisingly, there was a history of left ear discharge. You see, note that the MRI changes on the MRI are seen in the right ear, but there was a history of left ear discharge 1.5 months back, and there was no history of right ear discharge ever. So again, I got a little concerned कि ये कैसे हो सकता है? But then I further asked the history of decreased hearing, and there was a history of decreased hearing in the right ear since many years. And patient was actually using bilateral hearing aids since 2 years, but not very regularly and without much benefit. That was what the patient reported. And to complicate things further, there was a complaint of tinnitus in the right ear since 5 to 6 days, a ringing sound which was there throughout the day, even during sleep, even 5 to 6 days, like before the fall. So at this point, I am thinking what this might be, because the ear discharge history is in the opposite ear. The erosion in the mastoid is in the right ear, and the tinnitus is in the right ear, and the decreased hearing is in the right ear, but the active disease clinical is in the left ear. So, but there was a fall. There was a definite fall. So at this point of time, I just paused and I thought, ki, what are the differential diagnoses that I'm considering in this case? So obviously, senior citizen, sudden fall, you always keep a differential of a transient ischemic attack as the first, because that is what is more concerning. Obviously, with the history, the complicated otitis media was also one of the topmost differential at that point of time, because obviously most of the positive history was related to both the years. Obviously, sometimes, although the patient said she had breakfast, now this happened at home. There was like, it was not like she was outside somewhere in the sun or something. She was just standing, doing something, and she just fell. So, but still, sometimes hypoglycemic episodes can happen. So, I kept hypoglycemia as a differential. Although there was no sudden emotional rush or something like that, or a panic attack or something like that. But still, again, sudden fall, you always keep vagal syncope as one of the differentials. And one of the rare differences which came to my mind, because there was a history of obviously dizziness with fall. There was a history of tinnitus in the right ear and decreased hearing in the right. Although obviously Meniers has a typical history of episodes lasting for at least 20 minutes, half an hour, 1 hour, 2 hours, along with the other symptoms. But I was like, can this be a drop attack with a Meniere's disease, which was subclinical till now? Keeping this in mind, I went ahead with my otological examination, because now the patient had come with an MRI. My mind was concentrated towards the ear, so I started with my ear examination. Now, the left ear had a large central perforation with congested middle ear mucus. So there was active disease in the left ear at present. That's what I could see. The right ear was very narrow. The external auditory canal was bulging, and there was in fact some foul-smelling debris which I had to remove by sectioning and cleaning. After removal, the still the space was so the space in the external auditory canal was so narrow. I had to literally use a pediatric speculum to visualize the right tympanic membrane, which appeared fine, which was intact. But there was some foul smelling discharge which was there, which I had sectioned. So now again, I'm confused. The active disease in the left ear, there is not much in the right ear. Now, what is the culprit? I was still thinking. So I did my tuning fork tests. The Rinne on the right side, no response. There was no response at all. So it was most probably a dead ear. And it was negative for all three frequencies on the left side. So there was a severe conductive component in the left side. The Weber's was, as expected, lateralized to the left ear. I did the absolute bone conduction, and interestingly, it was decreased on both sides. On the right side, it was expected because there was a profound sensorineural hearing loss on the Rinnes. The left side, again, since it was decreased, so it could be just a mix. It was basically pointing towards a mixed hearing loss. Now, the cause might just be old age, it might be presbyocusis, or it might be disease process affecting the eighth nerve and causing a decreased hearing. So I was not very sure. So I proceeded to my further examination to rule out central and other ENT causes. But I was really stumped because the neurological examination was absolutely normal. Patient was absolutely fine. She could even at the age of 65, she could stand with her eyes closed on one leg, and there was no nystagmus whatsoever. And she had not taken any medication before coming to me. So apart from paracetamol for the headache due to the head injury. So and even the positional tests were normal. The big sulfide bilateral, the supine roll test, deep head hanging, everything was fine. So at this point of time, although everything was pointing towards maybe a complicated otitis media or something on those lines, my sixth sense was just niggling ki something is not right. So I was literally confused at that point of time. And then I thought, ki, okay. And this was, if I'll just tell you, this was during the peak of the first wave of COVID. So I was basically everyone was wearing masks. I was in my PPE kits with a face shield and a double mask, an N95 mask with a with a regular mask over it. So I at this point of time I was really confused and not getting a clue. And then I just remembered, at least there has been a fall. I'm suspecting there might be some neurological cause. Let me check the blood pressure at least. Let me check the vitals. So at this time, obviously the BD had narrowed down to complicated otitis media or a transient ischemic attack, with still an outside chance of a drop attack of Meniere's being there. So I uh, I told the patient to lie down. I started checking her blood pressure, and the blood pressure was very high. It was 170, 100. Never, and the patient was not a known case of hypertension. So then I thought this might have been a fall in blood pressure. So I was like expecting, okay, now there might be an orthostatic fall, but there was no orthostatic fall in the. So now at this point of time, because of the mask, my confusion was not visible to the patient, but the patient at that point of time, I could see that nobody had ever checked. She was like looking at me and like, what is this person doing? Why am I checking her BP in standing position? And because of the my mask and my PP cut, she could not see my emotions. But I was really, really stumped at that time. But I always think that we have five senses, and all these senses are given to us for a reason. And it is at such moments that you realize. Now, when I was checking the BP, I noticed something. So in all that confusion, I heard. You know what are the sounds which we listen to when we are checking the blood pressure with the stethoscope? They're called as Korotkoff sounds. So those Korotkoff sounds were very few and spaced out. I literally had to wait to hear the next bit. So now I thought now I was onto something. Now what could be the cause? I immediately called for a pulse oximeter, and the pulse rate of the patient was 37 per minute. Luckily, the center where I was seeing, it was a polyclinic owned by a physician. There was an ECG available. I called up the physician in his clinic, told him there's this patient over there. I think she will require immediate ECG. And an ECG was done immediately, and showed a complete heart block. And the patient was immediately admitted and underwent a permanent pacemaker implantation the next morning. So amidst all this, the patient had such a confusing picture of it either being a neurological or ENT cause of the dizziness and fall, but it ultimately turned out to be a cardiac cause. So this was a big eye opener and a lesson for me. Dr. Ravi, you want me to continue or we?
No, I think we'll break in here. I think
Yeah,
thank you
yeah.
for a very interesting presentation. So now I'd like to get in the
Sir, your
experts.
voice is a little low. Volume of your mic is a little
Sorry.
low.
Uh, so
Yeah.
am I more audible now?
Yes, yes, yes.
Yeah. So let me start getting in the resource persons at this point. So a couple of questions which I would like to ask.
Yes,
Uh,
sir.
Now, the first is, this is for the resource persons to tell us, quite apart from the case, how often do you get misled by MRI findings in ENT cases? So, Dr. Krupa, would you like to? By the way, do we have Dr. Bala on board as yet, or Dr. Bala? No, okay,
Good
Dr.
evening,
Krupa.
sir.
Oh, hi.
evening.
Great. Oh, thanks
Good
to see
evening,
you.
sir.
I've already taken the liberty of
Good evening, Dr.
introducing
Balakrishan.
you
Good evening.
and
Good evening.
your and highlighting your vast experience. Glad to have you on board. Could you put on your video, sir, so we could all have a look at you, if it's possible?
Okay, sir. Okay.
So I hope you heard the case and the
Yes,
very
I
interesting case presented by Dr. Onkar. So
yes, sir.
as I said, the first question before we get on to the case is, how often have you been misled by MRI findings, Dr. Kripa?
Yes, sir. As Dr. Omkar has, first of all, I'd like to congratulate him on a very nice case presentation.
Thank you, sir.
Having said that, because there was soft tissue in the middle ear and the epitympanum extending to the mastoid, naturally, as ENT surgeons, first we tend to think of, say, a complicated case of otitis media, which might have reached the labyrinth or something like that. But sir, first of all, just one small question I have for Dr. Omkar here. Omkar sir, was there a loss of consciousness in this patient?
What the patient told me that she realized that she was falling, but
No.
huh,
Yes.
huh. She did realize she was falling, but next 2-3 seconds, what happened, she doesn't know. Then she regained consciousness and then she got up. So for 2-3 seconds, luckily the son was in the same room. So he also
Right.
said she fell down. We thought she's not responding, but she got up by herself. She was not, but she got up by herself.
Exactly, sir. So why I ask this question is it is an answer to be determined by doctor rather than to be answered by the patient. When I ask this, what I mean is the top thing whenever there is a fall should be a loss of consciousness or not. Because 90% of the fall history, it literally tells us could
Yes.
it be a vestibular or say a ear related or say a cardiac or syncope related fall or epilepsy related fall. So that is one. So that is where a misleading MRI finding could not misguide us anymore because we have a very clear cut history and we boil down to the differentials earlier is my take on it.
Good. Thank you. Dr. Balkrishnan, I think
Yes, sir.
would love to hear what you think about this. I mean, let's restrict currently to MRI findings misleading, especially in
We
ear.
we see quite often patients presenting with MRI findings, which is confusing the picture on a regular basis. I would say about 3 or 4 for every 10 patients will have some findings in the MRI, or the MRI was taken by a neurologist or somebody and they say there is mastocytis or soft tissue and they get referred to us.
So
So
that's a good important point, which I think everybody should note, that MRI without clinical examination often misleads, and with clinical examination, in this case, of course, is a different story. The second point, I think Dr. Kripa has highlighted the question of consciousness and fall. So let's just go on to the next question, which I find very interesting. Dr. Onkar, I must appreciate the fact that you attempted a differential diagnosis at the end of history. So the question to all the experts is, do you mandate it to your juniors that you should always attempt a differential diagnosis at the end of history? Dr. Kripa?
Yes, sir. As Omkar sir's title suggests, कि whenever, do not miss the views. Whenever we have been taught during our curriculum, during our MBBS days, that whenever you hear hoofbeats, think of horses rather than zebras. So coming, why I say this is naturally there should be a common diagnosis that should come to our mind, and those will be our main differentials. Of course, we are taught as postgraduates or undergraduates that the rare diagnoses come towards the end, but habit. So this puts us in the habit rather of thinking out of the box also at times, like in this case.
Okay. Dr. Balkrishnan, I know
yes,
I'm laboring this point, but I think it's an important one, and that's why I'm doing it.
yes, I agree, and it's very good. He made a differential diagnosis. We should have a differential diagnosis. But what I do in my clinic, I have a protocol. So any fall, then we follow this protocol. That's what I do. And one of the things in the protocol is all the patients who fall, whether they lose consciousness or not, because that history is very confusing. Sometimes patients say, I fell down, sir. The attendant says he lost consciousness. Patient said, no, I was awake and all the same. So I don't insist on that history. Anybody who had a drop attack will have to go through event monitoring for two days. That is the ECG monitoring for 2 days. That's what we do.
Okay. So, you admit any patient with history of fall? Essentially.
No. I don't admit. We have a the same. We have a sticker-like thing. It's linked to the mobile phone. So it gets transmitted internet in the hospital records. 2 days later, they come and then everything is sorted out.
Oh, it's a remote holter.
Yes.
Okay. Hello, was there some question? No. Okay. So that's, I think, the point. I would like to, of course, raise a small objection to Dr. Onkar, saying that even though the patient was 65, they could stand on one leg. Being in that grade myself, I felt a little uncomfortable, but that's okay. I think you couldn't have known. So let's go on now to actually the important aspect of the case, and let me come now to Dr. Balakrishnan to ask you questions, and you're free to just go ahead for the next 5 minutes and talk about your experience of cardiology cases presenting per primum as dizziness or fall or whatever.
It is not uncommon. I would say every 2 weeks I see one of the patients with this kind of history, fall and everything. And important thing is sometimes the cardiologists, what they do is they routinely do a ECG, echo, and say everything is fine. I insist that they should have a holter for 2 days. So my request to the cardiologist is kindly do event monitoring. That's what I do. And quite recently, there was a case where the patient was the mother of a cardiologist, and she came exactly the same story. Everything, VNG, all the tests were normal. I told her most it is going to be arrhythmia. The cardiologist was a bit reluctant, and then they started this Holter. So the second day night, she had a similar episode, and then that time there was a cardiac heart block like thing. So she had a pacemaker. So I would say we should be very careful in people with who are elderly and fall. Younger people tend more to be epilepsy and other things. And other things are TAA and other things. He had a differential diagnosis. So I think that's very good. It's not uncommon. So the thing I find as we progress in the practice is, initially when I started my practice with Vertigo, we had only purely ENT cases coming to us. Then as people realize that you are doing a lot of work in it, so all patients with fall, dizziness, vague symptoms, everything gets referred to you. So it becomes even more important you have a wider perspective. Once you start doing a lot of work, then all these patients will come. So now we diagnose hypertension, diabetes, all those things, hypothyroid, all those things get referred to us because they say something is busy, you send to this fellow. That's what happens.
Dr. Kripa, I would love to hear from you, and also your protocol of examinations of all the patients with your, the thorough workup which you do in a dedicated Vertigo center. Could you just enlighten us with your experience?
Sure, sir. So, first of all, whenever, as we are talking about this case, I'll come to this. First of all, because it is a cardiological case that we know now. But there were no, as I listened to Dr. Omkar's history, there was no clear-cut cardiological symptoms that the patient mentions. For example, chest pain, palpitations, or any breathlessness, any exertional fall or exertional discomfort. At least if it was there, I missed it probably. But as far as I know, it was not there. So the only thing left with me in this patient was the history of falls. Now, whenever a patient comes with falls, first of all, we follow a syndromic approach. And as we all are aware that a history taking in a vertigo practice is utmost important. Of course, I definitely agree with Bala sir that the examination and Holter monitoring is the most important thing. But history only gives us a lot of clues. What do I mean by this? I'll just summarize in a quick sentences. Number one, if there is, say for example, this patient had a loss of consciousness. Now, whenever we talk, there are 3-4 diagnoses that instantly come to my mind as I'm talking to the patient. I ask the patient, do you remember those 2, 3, or whatever 4, 5 minutes of your life? Sometimes they say, yes, I remember, but I could not help myself. The other set of patients say, ma'am, I'm very sure I do not remember those 3-4 minutes at all. So that tells me it is a loss of consciousness. Now, whenever there are 3-4 diagnoses. Number one, the prime is syncope. Second is an epilepsy. With the rise in cases of migraines, there is also syncopal migraines which present with loss of consciousness. And finally, there is something, this conversion disorders. But of course, those are more common in the young population. Coming now, say for example, that the patient has preserved consciousness. They'll tell you, ma'am, I remember falling. I remember everything. My relative, my son running towards me, Arey, mama, you fell down. But I was unable to help myself. So this points us to another category of falls with preserved consciousness. Now in this, there is cataplexy, which has basically what happens in cataplexy is a loss of muscle tone. Now, since we all are in ENTs, I would like to highlight on vestibular falls. Vestibular falls are essentially energetic falls. They are high energy and dramatic falls. They also, of course, there are accompanying bruises and injuries which happen with them. And in this case also, there was a head injury. So more so, we could think of was it a vestibular, very high intensity fall? Another option, another diagnosis is gait disorders can present with preserved consciousness. And finally, I know it's very common, I mean, this cause, but patients, they come to us directly as fall. So we tend to think of all the pathological causes, but a simple environmental cause where the stool has, the patient has fallen down from the stool, or there's a loose carpet in the hall, or there is, say, a slippery bathroom. These are also the causes of falls. So history is the prime importance, of course, following which a regular BP protocol, or what we do, something known as a vertigo BP protocol. In that, we take BP and pulse first in sitting position, followed by in the lying down, then after standing at first, third, fifth, and 10th minute. Definitely, if there is to not even miss a delayed orthostatic fall in blood pressure. So say, for example, that the patient has a fall. Now, what do I mean by orthostatic hypotension fall? Systolic fall by 20, diastolic fall by 10, and or. So if that comes, definitely I recommend patient for Holter monitoring, as Bala sir has very nicely covered that aspect. So many a times, one of the patient came to me, this is very interesting. They said, ma'am, so I found the orthostatic fall in that on clinical examination. And when they came back, there was a clear-cut normal Holter examination. I asked them like, okay, was the machine attached, everything? Yes, ma'am. And I said, you went to work, you did all your routine activities. So the patient confessed, no, ma'am. The technician told me sit in one place for the entire 24 hours. That is what I did. So the that is how we miss the Holter findings. Probably there was arrhythmia at that time, but the patient, because he was seated in one place, when patient is on Holter monitoring, they should do all their routine activities with the machine on. That is another thing I would like to point out.
So thank you, Dr. Kripa. I think that was very exhaustive and, I think, an eye opener for many, especially the importance of doing the position. I mean, the BP examinations over a prolonged period of time. I think that's a good take-home message. But now let's get back to Dr. Omkar, because he has done some very exhaustive reading, and we'd love to hear from you your the results of your literature search and other things on this topic. Go ahead, Dr. Omkar.
Yeah. So obviously, after such a after an exhaustive discussion like this, uh, obviously you know now that this was a syncopal episode. So syncope. Syncope is defined as a transient, self-limited loss of consciousness due to acute
No,
global impairment of cerebral blood flow. Generally,
no.
the duration is brief, lasting for seconds,
இருக்க வா இவரு வந்துட்டாரு சாய்.
with
Dr.
spontaneous
Bala,
and
could you
complete
mute?
recovery.
Sir,
Yeah,
I
go ahead. Go ahead.
Yeah.
Go ahead, Omkar.
So
Sorry
generally,
for
the
that.
episodes are of brief duration, lasting for seconds, with generally a spontaneous and complete recovery, as was the case in this patient. Most commonly, the causes are vasovagal and cardiogenic. So obviously, vasovagal syncope generally seen if due to stress or a sudden emotion or panic. Cardiogenic, mainly arrhythmias. Like in this case, this patient had a complete heart block. Carotid sinus hypersensitivity, where basically extensive neck movements can sometimes cause a pressure on the or neck movements or a pressure on the neck vessels can cause the carotid sinus to be stimulated and cause a fall. Neurological, like sometimes even TIAs and strokes can manifest like this. And obviously, there are these convergent disorders and hyperventilation, which Dr. Krupa talked about. Now, because this was a case of complete heart block, just touching upon cardiac arrhythmias. Now, generally, the episodes, the clinical presentation is like the episodes are associated with lightheadedness lasting for seconds rather than minutes. Both bradycardia, which is a heart rate of less than 40 per minute, and tachycardia, where heart rate is more than 170 per minute, can cause inadequate perfusion of the brain, which leads to a sensation of lightheadedness or blackouts. Sometimes, obviously, in cases of tachycardia, can be associated with palpitations. There is generally a previous history of heart disease, which was not the case in this patient, but generally there is a previous history of heart disease. Obviously, you should ask for history of being on thyroid medication or any thyrotoxicosis symptoms or electrolyte imbalance. And interestingly, as I was reading, I came to know that the antiarrhythmic drugs themselves can cause arrhythmias. So you should always ask for the patients being on any drugs which modify the heart rate. And even tricyclic antidepressants, overdosage can cause arrhythmias. On clinical examination, obviously, as was seen in this case, you should take a pulse for a complete 1 minute. Look and look not just for the rate but also for the rhythm, because you will sometimes come across missed beats or prolonged gap between the beats. Obviously, blood pressure examination in lying down and standing position. And obviously, if the case is with the physician, they look for murmurs, or cardiologist, they look for murmurs. Investigations, obviously, ECG is the first line investigation in these cases, which generally gives you a diagnosis. But yeah, obviously, as Dr. Bala and Dr. Krupa pointed out, that the next best thing, if the ECG is normal at that point of time, generally the 2D echo is also normal, because this is a disease of the electrical activity rather than a structural disease. So Holter monitoring is very important. In cases where you are thinking of ischemia, treadmill test will help. And obviously, the gold standard being tilt table testing, where you are not able to even diagnose anything on Holter. Tilt table testing is the gold standard for diagnosing cases of arrhythmia, which have not been diagnosed by any of the above modalities. Coming to complete heart block, which was the case in this case. Complete heart block is actually a third degree atrioventricular block. It is an abnormal heart rhythm resulting from a defect in the cardiac conduction system, in which there is no conduction at all through the atrioventricular or the AV node, so leading to a complete dissociation of the atria and the ventricle. So there is a different atrial rhythm and or different ventricular rhythm. So if you see the ECG, the P waves will be more and the QRS complexes will be less. So the ventricular escape mechanism can occur anywhere from the AD node to the Pulmonary branch Purkinje's system. Coming to the treatment, obviously we always test for electrolyte imbalance, and if that is where you correct that, stop any arrhythmogenic drugs because they might be the cause. Obviously, you should always remove the causative factors, and obviously, but still, majority of the cases do require a pacemaker implantation as a life-saving measure. So coming back to the title of my slide, my presentation, the title slide. So basically, I when I was through with this case and got to know that the implantation is done, I just remembered this statement by Dr. Theodore Woodward, who was an American physician and a medical researcher, and it is a very statement which has stuck with me when I had heard it. That when you hear hoofbeats, think horses and not zebras. So basically, what it means is you always think of the common diagnosis first and not the rare diagnosis. As our teachers used to take saying UG, I remember all my physician and surgeon teachers, medicine and surgery teachers telling me, if you come to a rare diagnosis, you will be rarely right. So this is what. But another teacher, few years back, told me, when you hear hoofbeats, think horses, not zebras, but do not miss the mules. So what does it mean is that, as Dr. Bala Krishnan sir pointed out, that the not so uncommon conditions is what you should always keep in mind. You do not keep them in mind and do not totally neglect them when you are, especially in the cases where the history and examination are confusing. So that's why I thought it apt to name my presentation as "Do Not Miss the News," because this is what this case taught me. So what I learned from this case is, after this case, I started checking pulse and blood pressure of all patients of vertigo and dizziness. Even if sometimes it's a BPPV patient, initially I used to check in all patients. I used to check the pulse and blood pressure first, and then do the positional maneuvers. And what is the title, that keep the uncommon conditions or not so common conditions in mind, especially in the not so straightforward cases.
Wonderful,
So
wonderful.
yeah,
Go on,
and
go on.
in the end, in my learnings as a vertigo specialist, what I have seen is that as soon as the patient comes in and starts, even before they start speaking, obviously you see the patient coming in and you start thinking what this patient might be going through, and as they start talking, you try to look at certain clues in the way they are presenting to you their history and their examination. And aptly, the inner ear is called the labyrinth. So basically, like a detective, you basically try to roam around in the labyrinth of the inner ear and try to come at the site of the lesion and the diagnosis per se. So that's why I would like to end my presentation with one of my favorite detectives of all time. And the author of Sherlock Holmes was obviously Sir Arthur Conan Doyle, who himself was a very good physician. So that once you eliminate the impossible, whatever remains, no matter how improbable, must be the truth, which was a mule in this case. Thank you so much.
Oh, thank you, Omkar. I think we are benefiting not only from your otolaryngology, but from your vast reading. So I
Thank
tip my hat to you.
you.
So let's deconstruct this case a little for our next 5-10 minutes, and then maybe throw it open for comments. So a couple of points which I think I've already started taking home, that you never meddle with protocol. Have a protocol to examine patients and stick to the protocol. If you jump the protocol, your risks of missing things are higher. The second is that drugs individually have problems, but I think we need to think of what is known as drug to drug interactions, because many cardiac rhythm abnormalities are caused when two drugs interact and cause problems.
Yes,
So
sir.
I think we need not be afraid of check. It's impossible to mentally keep all the drugs and their drug to drug interactions. Therefore, we should have an access, if necessary, online to drug interaction databases, because that would.
Yeah. Just a
Sorry.
small point,
Yes.
because many of these elderly patients are on polypharmacy. So I absolutely agree with you. time because of this, there'll be an anti-diabetic, anti-hypertensive, and anti-lipidemic. So many a times that is the only reason. So drug review is very important. Thank you.
Correct. And the last
One
point.
point I would like
Go
to
ahead.
just
Go ahead.
going over there, because a very important point regarding drug interactions. So generally, what helps is having a good relation with the treating physician. So basically, if you think that there is a drug interaction which is going on, the treating physician generally, because there are blood pressure, diabetes medications, sometimes heart failure medications, ischemic heart disease, so polypharmacy patients. So basically, when you call, you can just call up the physician and tell them that what you are thinking, and many a times they just do the needful and the patient is back to normal. So just one point.
No, that's great. And of course, the last point which I would like to say is follow up is important. Because many a time patients with cardiac problems can go on to having TIAs and strokes.
Sir.
So I think that you should keep this in mind, especially in this case. It'd be very interesting to know how she went on further. And if I may add one to this, in history, there is always a preferred history which the patient says. But often after diagnosis, if you go back to them with the knowledge of what the diagnosis is, they admit that they would have had cardiac palpitations, etc. So I think that's the last point I would make. But now I ask our commentators to please give any other thoughts which come to mind before I throw it open to the house. Dr. Bala?
One more thing is you have to observe the patient getting from the chair. So they may have a weakness of the hamstring muscles or joint problem, how they are moving, and whether they are able to balance themselves while walking. So a lot of these people have knee problem or muscle weakness of the knee. So that is also the reason for fall. And we have to think about Parkinson, atypical Parkinson's. That is another condition which will present this fall. They may have one fall. So these are the differential diagnoses. But once you see the patient, you know which direction you have to.
Perfect. So I think now let's just throw it open to the house if there are any questions or comments.
One point I would like to add in this case.
Go ahead.
So that would be a history. Always, whenever this kind of a patient with low pulse comes to you, always ask a history of beta blockers. Whether patient is on beta blockers, that is a very common drug which people take for hypertension and other cardiovascular causes all the time. But they don't find it important. Is number one. Of course, if patient is a very seasoned athlete and all, like Virat Kohli, they say has a heart rate of 40 beats per minute. So a seasoned athlete is an exception to this, professional. But otherwise, always ask a history of beta blockers is one thing. And yes, sir, coming back to your comment that we would like to know how post implantation, pacemaker implantation patient was. One thing I'm definitely interested if Dr. Omkar can tell us, since we have the recorded baseline BP of 170/100, right?
Yeah.
Which happens because of the sympathetic drive,
Yes.
because of the low cardiac output. So I'm really interested in knowing if post the pacemaker implantation has the BP drop down. Of course, she's 65 plus, so this is also a higher. They will have a higher BP normally because of the
Yes, yes.
age. But then, was there? I'm just interested in that factor, sir.
So what happened was 2 days after the implantation, she was admitted in the ICU. They called me just because there was active ear discharge again.
Right,
So
sir.
at that time, I checked that I again checked the blood pressure on the monitor and it was fine. So it had
Okay.
come back to normal.
Exactly, sir. So post implantation, usually the blood pressure should come to normal if there is a complete cardiac block. Thank you, doctor.
Yeah, and she did follow up with me a few months back just for a hearing issue, but she was absolutely fine.
No falls and all after
No
that.
falls or
Great.
any after that. Yeah.
Right, sir. Thank you.
So now I'd like to throw it open to the house. If anybody would like to pass a comment or ask a question, we are welcome to, so if anybody in the audience of, I think a sizable number of people have checked in, we just hope they haven't gone for dinner while watching.
Omkar, can I ask one question? I'm Dr.
Go.
Vaidya here.
Tell me, Dr. Vaidya, please go ahead. You
I
could
want
put
to
on your
ask.
video if you can.
No, it's okay. I'm from home, so I'm speaking on my t-shirt and all, so that's okay. But Omkar recognizes my voice. I can put up my video, no
No,
issue.
no,
Just a
Sir,
moment.
sir,
no
sir.
problem.
Hello, sir. Sir
Yeah,
was
yeah,
my head of department at Somaya Hospital.
yeah. I have put up my video also. So, Omkar, I just wanted to know what was done for the treatment of her ear disease subsequently.
Sir, she did not want anything
I-
to be done because she did not have any active complaints apart from the hearing. So she did not
Okay,
follow up with me. I did suggest to get a proper HRCP done and let's see. But they're like, "Ki, right
yeah,
now I don't have any problem, so I don't want to do anything."
yeah. But I missed some beginning of this particular session.
Yeah.
So I
Uh,
just wanted to ask you what was the reason of doing MRI because of her falls?
because of the fall and head injury, sir. So it was done
Okay,
by a physician,
okay,
and because that showed mastoiditis and erosion of the mastoid bone, she was referred to me by a colleague.
okay. But as far as the prognosis of that mastoid disease is concerned,
Mhm.
though it is nicely picked up by you as a heart disease,
Yes, sir.
thanks to your clinical acumen, you
Yes,
picked up that because many ENT surgeons may miss that. I'm not saying all, but many people can miss
True, sir.
the cardiac issue. You picked it up nicely and took the blood pressure of the patient, and you saw that her pulse rate was 37, and then she was admitted, and her pacemaker was done, everything was fine. But if the progressive disease in ear continues and she doesn't want,
yes, sir.
so can that also lead to the fall attacks subsequently? That is my
So
this
that
thing.
is always a risk, and I have explained that to the patient, but they were quite clear that they don't want anything to be done.
Okay, okay. So the patient is regularly following your.
No, sir. She just followed up once a few months back. I again suggested we just do a repeat imaging and see what is the situation of the right ear. Luckily, the ear picture had not changed much. The bulge was there, but the tympanic membrane was intact, and the left ear perforation was dry. So,
Great. So, Omkar, it was very nice case. I was listening throughout the initially I
thank
missed
you, sir.
10 minutes. And Ravi sir, Sankhe madam, and Balakrishnan sir, great.
Thank you.
So,
Sir,
thank you, Omkar, for
thank you.
clarifying, madam.
Thank you, sir.
Thank you, sir. It was nice to have you, sir, in the meeting.
Thank you so much. Thank you.
Uh, Ravi, sir, we have a few questions in the chat box.
Go ahead.
Right. So Dr. Ria Enamul, hello, ma'am. She asks, first of all, she wants me to explain my BP, Vertigo BP protocol, sir, that we do at Disease. Sure, ma'am. So what we do is, naturally, as Dr. Omkar has already told, a pulse is taken clinically for 1 full minute. Followed by, we have a special, since it's a dedicated Vertigo setup, you have a GC ka BP machine. So which checks pulse and BP, and that the one that they use in the ICU. So as I mentioned earlier, a sitting BP is taken, a resting BP. Then after lying down should be quite lying down. They should not be talking to the attendant or should not be talking to the examiner or that way. So it should be quiet lying. After quiet lying, you ask them to get up, stand up, right? At 1 minute, 3 minute, 5 minute, and 10th minute, BP as well as pulse are recorded. So that is the BP protocol, madam. And according to the findings, then the further it is decided whether the patient needs a Holter and a head-up tilt test. So I hope that answers your question. Yeah. So the next question, madam has for Dr. Omkar. Dr. Omkar, Dr. Ria asks, the patient's EAC was narrow on the right side. Was it due to otitis externa, sir?
No, no, I think it was clearly because of the disease in the mastoid, which had eroded the extraorbital canal also to some extent. I think that was what was causing the bulge.
Okay.
I think, as Dr. Vaidya pointed out, that's a ticking time bomb.
Yes, yes.
Maybe you should be a little aggressive in getting them to get operated. Just a suggestion. Anyway,
Yes, sir. Yes,
I'm
sir.
sure you know
I
them
have
best.
done my counseling, but it's up to them.
Okay.
Sure.
So here's a question which I think Kripa, you want to take some more questions? Some are
Sure, sir.
directed
Sure.
to you. They have come
Sure,
to
sir.
you. Yeah.
So Dr. Amit Thote congratulates Omkar sir on an excellent presentation.
That's
Dr.
taken as read.
Shilpa Hotkar is asking, is there any role of vitamin D, ma'am? In what? In vitamin D in vertigo, or in this case, I would, if you can ask that clear question, that will be more helpful. We'll be able to help you better. So as ma'am is doing that, Dr. Amulya Totambailu. Hello, ma'am. So she says in a busy teaching hospital OPD, following this BP protocol might be tough. Can it be modified when there is lack of time? So Dr. Omkar.
No, I think here's a question which I think Dr. Bala and you could take, and then Dr. Omkar.
Sure,
See,
sure.
a traditional examination of a vertigo case can never be disposed of in a busy OPD because the chances of your having to jump the protocol is always there. So when I was in the medical college, we used to call all these patients in the afternoon so that we get a poor junior to go through and fill up the forms. But I think we all need to think about ways and means of, because I think India has always been besieged by numbers of patients. So this question now to Dr. Bala, how do you tackle numbers?
I'm a general ENT clinic. I don't have a dedicated vertigo clinic, although I see a lot of vertigo patients. The problem with having a specialized vertigo clinic in my setup, which is corporate hospitals, nobody bothers to come on that particular day. They just walk in and they say, I came for a cardiology review and coming here. And so it doesn't work. I follow your idea, sir. I usually do all the blood tests, VNG, and other things. I give them the DHA questionnaire. So by the time they do all this thing, it takes about two hours. So I'm free by then. So I sit and slowly analyze things, and we have all the information. That's what I do. I don't think, and sometimes if I'm very tired, it comes to 2:30, I'm hungry, I say openly to the patient, I'm hungry, I can't think, come back after 1 hour. Or sometimes I ask them to come the next day. If I'm very busy, I say, no, I want to think, I don't come. That's it.
Sir, one tip for Dr. Amulya, what we used to follow as DNB students in New Delhi. So they used to have a dedicated Thursday afternoon post lunch will be a Vertigo clinic day. I was the in charge of that Vertigo clinic day, so I have a very lot of memories around it. Like all the patients would line up, and our minimum OPD per OPD would be around 200-300, since it was a state government hospital, only one in that West Delhi region. So, ma'am, dedicate, you will have a lot of residents around you, I'm sure, since you're in medical college. So you can allot them turn by turn in for a Vertigo day. So it's quite easier than Dr. Bala's schedule, Bala's schedule here. Yeah.
You may need more than one day. We have a hand up by Dr. Pratishtha Sachin.
Yes.
Dr. Pratishtha, please ask your question. Unmute and go ahead.
Hello, Pratishtha ma'am. Good evening.
Good evening, Dr. Pratishtha.
I think she's got tired of raising her hand. Hello, Dr. Pratishtha.
So in the meanwhile, can we take another
Sure, go ahead.
question?
Go ahead.
So Dr. Dhanya congratulates all of us on a good presentation for Dr. Omkar and very good discussion. Apart from, so Dr. Shilpa has got back to us saying she wants to know the role of vitamin D in vertigo. So,
Good, Dr. Bala. Anybody? Kripa, you want to take it?
sir, I think Bala sir will be the best person to answer this. Yeah.
If you check the vitamin D and if it's low, you treat that condition. But per se for vertigo, I don't give vitamin D as a regular medicine.
No,
I tend to give a lot of vitamins for patients with vertigo, particularly thiamine. This I learned from Srinivasan sir. But vitamin D I don't say give for this.
Sorry. Okay. No, I think the context is that nowadays it's become a corporate must-do vitamin D, and almost 80% of the people checking vitamin D have low vitamin D. So, Dr. Pratishtha, have you come back online?
So Dr. Tabitha is here with us. She's from Kenya, and she joins from Kenya, and she was one of the participants in our last year's AMBD course. So hello, ma'am. Welcome to you. She asked a question in the chat box: for how long has the patient to lie down before, actually we check the BP. Ma'am, it's 10 minutes. 10 minutes of quiet lying down. Yes.
Good evening. Good evening, all. Hi,
Hello.
Dr. Kripa. Happy to see you on screen after a long time.
Thank you.
It was a very nice presentation. Panel also was very nice. And I would like to share one patient whom I remember this time. Actually, I had an elderly lady whom I was following up for 1 year. She was having recurrent vertigo. Actually, no diagnosis, well, like it was coming out, everything was normal. So she was put on antiplatelets, and for 1 year, she was doing well. And suddenly, what happened is she stopped the medication by herself. And after 2 months, I saw her in the ICU. I saw the bystander. Then he told, my mother is in ICU. She had stroke. Then I felt that, since she stopped the antiplatelet, maybe that is the reason why she got the stroke. So I was connecting with the neurologist. Then what he told me that she had vertigo while she was in ICU, and that at that point of time they picked out an arrhythmia, and neurologist told me it was a case of cardiogenic stroke. So for 1 year I was following her. So since it was a cardiac case, I remembered this patient. Yeah.
Thank you for sharing that with us, ma'am. Thank you.
Go ahead. Any other questions on chat?
So we are still waiting for Dr. Pratishtha. Are you here with us? So in the meanwhile, Miss Tabitha from Kenya again congratulates Dr. Omkar on a great presentation. So a
Thank
lot
you
of
so much, Mary.
congratulatory messages
Thank you so
there.
much.
So I think if there are no more questions, you think we should wait for Dr. Pratishtha, or she's gone offline?
Sir, I'll try calling her once, if you allow me, in a minute.
Please,
if she
go ahead. Go ahead, just try. So now here's a generic question which I throw open to everybody. What is the role of, because there's now increasing threats of AI and ML and all that coming into the picture. Do you think that's going to help us in vertigo, or do you think it's going to be a difficult thing to tackle? Okay, Dr. Pratishtha has come back. You're on mute, madam. You're on mute. Unmute yourself.
Sir, Dr. Pratishtha is here with us.
Yeah, but I think she's on mute.
Yes, she'll have to mute. I'll just call her.
She is unmuted.
She is unmuted, I believe.
Yeah, we can't hear you. We can't hear you, Dr. Pratishtha.
Okay, sir, I believe there's some technical issue. Maybe her source of output of sound is not the one which is...
She can tell you on the phone and we'll attempt to answer.
Why not? I'll do that. She's typing in the meanwhile. I'll just call her. Just hold on. I will say. Sir, ma'am has a patient. She's planning operation in TAVI hospital, TAVI operation in AIMS. Okay. It's a valvular issue she's facing. Tricuspid valve seems to be the issue. Okay. Okay, so now this patient has presented to ma'am with a fall. I believe there's a tricuspid stenosis that the patient is known to have. With the fall, now she also has lateral canal apogeotropic nystagmus. Ma'am, am I right? Geotropic variety of lateral semicircular canal VPPV. Yeah. There's a head injury. Yeah, so for her, okay, I have lost the signal, but anyways, what I could gather is twice Dr. Pratishtha has done barbecue roll for this patient. Once she has done Guffoni maneuver for the patient. I believe the rest, ma'am can just type it out. So this is the history so far. So you want me to recapitulate it probably?
No, go ahead and take it. The question I didn't get.
Uh, yeah, she's typing, sir.
What is the duration since fall?
So ma'am has not mentioned that. She
Okay.
said only the patient has presented to her with fall, advised a TIVA operation at AIMS for her tricuspid stenosis, and now has a geotropic lateral canal BPPV. So probably it's not getting treated, is what I assume.
She says not relieved. The vertigo is not relieved.
Yes, yes.
But that would be expected. I think you need to address the primary cardiac problem. That
Yeah.
would be my priority.
So I would like to ask this question like to Bala sir. Clearly comes from a vast background of experience. So sir, like TAVI operations and this one, like I am hearing for the first time. Like, could you just?
If the fall is quite recent, I won't bother to do any positional maneuver for them. What I find is a lot of these people may have a small uh, uh, blood in the lateral semicircle because of the injury, and that behaves like a autocoria. So there is a lot of confusion. So I would just leave the patient for 1 month and then get them back again and do the examination. 90% of the time, everything is sorted by that time. Okay, that's what I would do. And if the patient has,
Go ahead.
and cardiac patient, I would.
Vishnu, could you just mute the non-video participants, please?
For cardiac patient, I would first, like Sir said, Ravi Sir said, I would go for the cardiac treatment and then see what happens after that. So in either case, I won't bother doing anything for this patient except prescribing Vertigo. Just let them settle down and then go for the cardiac treatment and then revise the patient.
Right.
Thank you. So I have one. I think we should be winding up now, but I'd like to pass. To point out one question on the chat. Dr. Parul wrote, "I lost my father because of a delayed diagnosis of cardiac arrhythmia while he was having vertigo for more than 20 days." So I think this is something which we all should note, that vertigo is not equal to ear abnormalities.
Yes.
I think we have fallen into the trap of seeing the world through the ear.
Yes.
I think we should move out of that mental frame and see the body as a whole. I too have found a case like that, and that was one of my students who came with vertigo. I examined and I couldn't find anything, and I told him, "Look, my side there's nothing. Please go to the neurologist." I lost track, and then again 3 months later, the student came back saying he passed away, and said, "Could it have been the vertigo?" Of course, I had a defense that I send it to the neurologist, but then I always feel guilty within myself that I didn't realize that vertigo could also be a warning sign. I mean, I did realize, but I didn't emphasize it hard enough. So I think the take-home message in this instance would be the importance of follow-up. Again, I don't think we are practicing ideal medicine. I don't see any difference in the practice in 1980s and the practice now. We are still, quote unquote, disposing patients. The numbers game is against us always. In my stint abroad, I remember we used to give, half an hour appointments minimum. And I was so habituated to quick disposal, my half an hour would be 20 minutes talking to the staff nurse, because in 10 minutes I had the diagnosis and the wrap. So, and then the next patient would come only after half an hour. So I think that's an effect of the conditions we work in. So, but I think we had a very interesting discussion. thanks to everybody who participated, Dr. Omkar in particular, Dr. Kripa for her vast and very methodical knowledge, Dr. Bala for sharing his wide experience. The rough take-homes would be that the history is important, both what the patient tells and what you can counter ask, number one. Number two, follow a protocol and fix the protocol, standard protocol. There's no rocket science. The third is that drug-to-drug interactions can occur. And along with a lot of other take-homes, which I'm sure you had, we should always see the body as a whole. Difficult in a COVID time, I understand, but see the body as a whole and don't ignore anything, however small, whether horses, zebras, mules, or giraffes, everything would come out thereafter. Thank you, Dr. Omkar. Thank you,
Thank you,
everybody.
Thank you, sir. Thank you, everyone.
Thank you, Omkar. Fantastic presentation.
Thank you.
Thank you so much.
Have a
sir.
great long weekend, everyone.
Yes,
Thank
yes.
you. Thank you.
Good night. Thank you so
Thank you.
much.